Everyone's loving the K-pop, right? Bonjour tout le monde, rebonjour. J'espère que vous avez bien mangé et pu échanger avec quelques collègues. Maybe for those in the room, if you could come have a seat with us, please. Good. That means you too, Rita. OK. Revenons maintenant à notre programme afin de réfléchir à l'avenir de l'écosystème des données de santé au Canada. I hope you had a great lunch and some good hallway chats, and now it's time to refocus as we look ahead. In our last panel, I think it was Pyle reminded us of the importance of trust. And so that's a perfect segue into our next leadership session called Building Trust, Unlocking Potential, Canada's Health Data Future. It's about something fundamental, how we create a trusted, connected, and equitable foundation for sharing health information across the country. Or as the kids might say, a foundation that gives us 6-7 energy? No. I can't believe you made me say that. I did run it by my 13-year-old, and he said it was tough, and I'm pretty sure that means good, so we'll keep it in, but we'll try not to give you any more. Anyways, please join me in welcoming to the stage EVP of Connected Care, Abhi Kalra.
Thank you. Good afternoon. It's a pleasure to be here and presenting to you all, who are all accomplished in your own fields in your own way. I'm going to use the next 45 minutes more as an engagement, share some learnings, but at the same time, an opportunity for me to learn from you if we're going down the right path. It's a bold vision that we're going to talk about in the next 40 minutes or so. It's something related to what we have heard this morning. I was making notes. The great presentations, the moderator sessions that we had since morning, there were already so much richness in their feedback, in their suggestions, and I made note of some of those. So I heard status quo causes harm in healthcare. I heard the most inspiring patient story about the importance of respecting the diversity of data. We heard pragmatic approach of building on the success, incremental growth once you have the groundswell. We heard embrace AI, but manage the change. And we also heard how to win the trust, with providers, regulators. And then finally, the most important one was when in crisis, we often go into silos. And I think that's the most dangerous reaction to crisis, which is what we need to avoid. All right, so the first piece, let's talk about the challenge, and then we're going to talk about a macro solution where we all need to come together. I think some of you may have seen this picture, but this is my favorite picture when we look at a health system, and I think you could pretty much replace Canada with any other country here. I picture myself in the center there as a patient. I picture myself as a caregiver in that picture, where hundreds of millions of health encounters happen in our Canadian health system annually. And if you look at the distribution, two-fifths of those interactions are happening in the primary care, which means a significant amount of my health information is stored there. But then you have the walk-in clinics, the hospital settings. You've got the emergency rooms, specialists, other community settings, which we often don't pay enough attention to, but the opticians, the allied professionals, the chiropractors who also play a critical role in case of chronic patients. And then two other aspects which are not on this slide are the pharmacies and the labs. Now think about it, that's the ecosystem of our health information. No one setting has full information. And we've been grappling with this information for about 20 years, since the digitization happened. So keep this picture in the mind, whether you are a patient, whether you are not a patient, whether you are a caregiver. But I would also say, I also see a voter. I vote, based on my healthcare experience. So keep that in mind, as we discuss this. Cost of inaction, I think we don't need to, again, continue to talk more about this. I think there are Everybody in this room is aware of the challenges, but some of the articles, further highlight the credibility and the criticality of the situation. More than ever, our health systems need to talk to each other. When you see different doctors, you shouldn't be just confined to go to your own family doctor who can provide you full care, but I think you go to other settings as well. Paperwork is hurting physicians, so where do we go from there? And finally, this is the most critical one. Our friend Dr. Affleck wrote, interoperability saves lives. Gaps in patient health information has costed life, and there are enough evidence of that. Transformation imperative. So where do we go from here? What do we do? And start to actually translate some of the abstract, some of the macro suggested solutions into tangible actions. And that's what I'm going to focus on the next 30 minutes. Massive amount of digitization has happened in the last decade or so. Digitization does not mean connectivity. And I think we heard from Payal in the last panel. Tremendous amount of digitization without connectivity, without meaningful interpretation of data actually is a burden. So we are at that point right now. We've done very well to digitize all our health settings, but we now need to move into the next transformation phase where we need to make sure that these assets are stitched together and they're able to interact and talk to each other. Focus, I know, for the last few years have been on interoperability, and there have been always some critics around, okay, what value does interoperability bring? It's a technical term, it's a technical jargon, it's a problem that we haven't solved, for 2 decades, and we still continue to actually blow the same trumpet on that one. But I think connectivity has suddenly become most important because in the advent of latest gift that we have received in AI and the capabilities of AI and the huge potential of AI, interoperability has taken a little bit of a better seat because the problem that we used to solve as humans to make systems talk to each other, AI can actually do the job for us. But for AI to do that job, we do need connectivity, and we do need a trusted connectivity. And I think that's where, it's the transformation imperative because all our 13 health systems have been built on an old model. So we have to, this is an appeal right now for us to actually look at those infrastructures, to look at our current models and see, does that work in the advent of how fast, the world is moving and the technology is moving. Business case, someone talked about the quintuple aim this morning. If you look at, as a public health system, I think I've said this a few times, the better health outcomes, patient care, provider experience, health equity. As a public health system, it's rooted into our day-to-day delivery of care to our patients. And we often, for the last 2 decades, we ignored the cost goal of the quintuple aim. And we said, it's a public sector, let's just continue to pour more dollars into the service delivery and continue to deliver healthcare. But it hasn't actually enhanced the experience. It hasn't delivered, the outcomes, that we have promised. And now suddenly what has happened is that particular lower cost quintuple aim is flashing red into our faces because there's no more money. We all know that, so the escalating cost in the healthcare is not sustainable. So we are now at that crossroads, where we have to really make our health system efficient, lower the cost of delivery. So it's a big challenge ahead of us, and we cannot actually manage that transition and the balance unless we look at the transformation imperative, that we talked about. Today's cost duplication, I think it's my favorite word. We all are paying duplication tax, and I think we have our wonderful client vendor partners in this room as well. I look at the distribution of this conference, roughly about 60% is private sector, and the remaining 30-40% is the public sector stakeholders, medical associations, clinicians, and the patients' voices. But when you look at it, I think each one of us in our region, we're paying a duplication tax. The reason for that is, because we're trying to solve our problem in silos. So that's a big, stark reminder to us that we need to start looking at that seriously. Separate agreements. There was a mention in the previous panel about the information sharing agreement. Today, the current state is, and I think there are a couple of regulators in the room as well, and a couple of lawyers as well in the room. Every time a single clinic has to exchange a record with a single institution or hospital, it needs a new information sharing agreement. And the cost and the effort behind standing up and signing that information sharing agreement, you start to multiply that across pan-Canada. It runs into millions and millions of dollars, but very important time. So something to focus on, and when we get to the solution, we'll talk about this. From a vendor standpoint, where nearly 100% of our EHR hospital systems are running on 3 or 4 big vendors, and 100% of the primary care setting is running on 3 national vendors. It is really important that we start to move into pre-built standardized interfaces. From a technology standpoint, why do we need to actually build new interfaces every time we go into a new product? Identity audit and security. Those policies, I think we have. I can probably boldly say we have used them as red herrings, but we've often used them to actually create a barrier in terms of advancement. I think we'll talk about how we could actually win or win the trust of the regulators, because we have not been able to, as implementers, we have not been able to understand the current policies and implement in the system and show it to the regulators and win confidence. We haven't done that. So the gap between the policy and the actual implementation is huge. And that's the gray zone, which is the interpretation of these policies into system-built requirements. And I think that's where we have failed, and we need to look at that. So with trust framework, I think, I'm introducing the trust framework term now, but it's really a network, and we'll get into more details. But it really focuses on, from a transformation standpoint, this is where it focuses on why don't we have one information sharing agreement that still allows for flexibility within those information sharing agreements, and why do they have to be paper agreements? Why would we not have digitized information sharing agreements? We're using digital tools, but we're signing Adobe PDF documents, right? Why don't we have electronic agreements as part of those digital tools adoption? So I think that's something that we need to look at. One certification, Andrew, during his pro talk, showed or demonstrated one step forward in announcing a pan-Canadian conformance service. Why are each jurisdictions trying to do their own conformances? When we're dealing with the 3 vendors on EMR and 3 vendors on the HIS system, it's cost, right? So Andrew's announcement was a step in the right direction to at least build that infrastructure, testing infrastructure, and now we have to actively recruit and convince all the provinces to start using it rather than investing into their own infrastructures. Let's talk about the economic value of the health data. Alberta Connect Care program, I saw Michael and Quinn Ma somewhere in the room. But when they build the business case for one HIS system connected with primary care and be able to actually access the information from anywhere about patient, projected $2 billion in savings over the 10 years. US, who also happens to be very closely aligned on some of the work that we're doing in Canada on interoperability. They have a trust exchange framework. It took them 9 to 10 years to stand it up, and now it's churning out about 100 million transactions every month. And they have predicted just the value of sharing the health data across various settings is projected to be about $330 billion over 10 years. OECD, another very credible organization, data mapping across various countries, both developing and developed countries, and they predicted better sharing of health data, irrespective of the sector, but let's say health sector, could actually generate 2.5% of GDP value. This is just sharing of data, nothing more, nothing less. And in context of Canada, if you add the private sector, because 20% of the services are still delivered by private sector, if you add that, we're probably looking at 3.5% of GDP of healthcare. For record, for those of you who don't know, we spend $350 billion every year on healthcare. So this translates into 10 to 15 billion annually. And we did a pretty bottoms-up modeling on one of the use cases, which is around if everybody in the country is able to, or every single region, every single jurisdiction is able to exchange patient summaries, for care, it will start to unlock about 7 to 8 billion in the inefficiencies, within the system. I talked about a few examples, but it's noteworthy to build on the current example of TEFCA, which is happening in US, is the latest announcement through the CMS was Trust Exchange Framework was really built on the provider-to-provider exchange, clinics to institution exchange, but they have now added a very important dimension to it, which is the patient. And they are saying the patients should be able to access their electronic health record from any platform of their choice. And that's a very big move, from their perspective, and they have a private sector backing behind that. But I think that's what we have to note is that mandate is coming top down from the government, so there is definitely a movement going to happen there, and I think that will unlock the access problem. Some of our European friends are here as part of the Global Digital Health Partnership Conference, and we have something to learn from how they have regulated the latest, European health data space, where all European countries, will be regulated to exchange health information, through common standards. It's going to take several years to implement, but they have already made the step in the right direction. So something for us to look as a model. Where do we go from trust framework? So let's spend maybe 5-10 minutes on understanding what is trust framework, and I'll try not to be overly technical on this. But if you focus on the trust framework, and let's focus on the top half of the slide. In healthcare, we do not have a One Canada project. I think in the last 6 months, there have been really some big movement around continue to identifying big One Canada projects, whether it's in the energy space, whether it's in the pipeline space, whether it's in transportation. But in health, we haven't talked about, what could be that, One Canada project. Trust framework is a very promising candidate, that could actually pretty much operate across the full spectrum that you see. Whether it's a local community where you would want to make sure that the hospitals, the EMR clinics, the long-term care centers, and the pharmacies are connected with each other and respect the federated nature of them, or whether it is at a region level, or whether it is a provincial level. And finally, once we get there, I think we probably will be at a point, where we can say, yes, all our 13 different health systems today are capable to talk to each other for patient care. But the solution, if you look at the spectrum, the solution is not different every level of spectrum. It's the same solution, respecting the federated nature of system of records, rather than trying to bring everything centrally, which was a model probably 10, 15 years back and probably worked, but respecting the federated nature of a system of records, but finding a trusted way to connect those and be able to receive and send the information when the care is needed. And that really is the fundamental behind the trust framework or trust network. I used ChatGPT, Gemini 2.5 version so this is not my intelligence, but I'm quite convinced, with what it produced. I said, in layman terms, explain it. I'm going to go into a conference and tell me how can I simply explain what a trust network or framework is. So this is what I got, from them, and I think I could very easily relate to all of those things. It is a shared foundation, and keep that spectrum in mind, community or region or province or pan-Canadian. It is a common set of rules, policies, and standards, which everybody agrees to. When we connect to this network, this is what we agree to do. It's a governance and accountability model. Whoever is participating in that network is accountable to participate in that model and respect the rules of the road. It's a legal and technical foundation, from exchange protocols, but also from an agreement standpoint. It enables interoperability by default, because when you set the rules of the road, when you set the rules of participation in the network, you drive interoperability by default. And finally, it's a facilitation of collaboration. Again, as I said, whether it's the facilitation of clinics and some hospitals together, or whether it's the whole province together. And it's one common blueprint. I also took the liberty, so let me go to the next slide and then I'll ask. It is not a technology platform or a software. It is only a mechanism to ensure that the two settings could actually connect to each other and trust each other. It doesn't hold any data. It is not a data repository. It does not replace any privacy or security laws or regulations that we have. In fact, it respects the nuances there. Not a one-size-fits-all solution. And on its own, it doesn't say that the organizations and clinics can now ignore their own guardrails within their clinic. So that's what it said. I also said, is this relevant for Canada? And for those of you who are already on devices, you can check. I got a resounding yes. And then I asked the next question. I said, what is practically possible? How long would it take, to build that network where we all will be connected and providers are able to access and exchange information about their care, and as a citizen, I can get a full view of my record. It could take 3 to 5 years, but something could be delivered in the next 12 months if everybody comes together. So I think there is some optimism there, and it gave me some confidence. Let's draw some parallel to some of the other industries. Look at Interact. So go back 15 years. If I was with TD Bank, I could not go to RBC Bank to withdraw my money. That is not a problem today. It's working through now, because this is why all the banks came together, all the financial institutions. They said, we have to do this if we have to provide consumer experience, and they actually developed a trust framework for bank. That's exactly what it does. Set of common rules, set of common policies, and they are participating. They co-govern that network. And they decide together who participates in that network, who onboards on the network, who offboards on the network. So it's working in other industries. So I think there's a requirement for us to look at it. And I understand, when we drop the word pan-Canadian, everybody's a little bit, stepping back, saying that, oops, that's going to be a big honking ask. But I would say, I would encourage, we need to look at within our communities and at least within our jurisdictions. And then I think, we can expand or organically grow from there. But that's a great example in this model. We already talked about, I think there are 3 key elements. This is not a technical framework, I would say. Often Infoway is looked upon as that technical SME geek organization. Yes, we are. We always look ahead from a technology standpoint, but this problem, we're trying to look at it, very holistically beyond just the technology. This is about, common governance, and this is not an administrative governance. We're talking about participating governance, defining the rules of road together. We're talking about common information sharing agreement on how this could really optimize. And I think it's a bold vision. It's a bold proposal that we're going to put together in the coming weeks and months, for all of you and others who are not in the room to consider. And finally, it's about common technical framework. Again, visually, if it helps, this is our reality. This is what we deal with as a health system. And you see those locks within every single setting. Those are the trusted locks. If these settings participate in the trust network, that's what they get trusted locks, and they're able to actually trust the other setting when they send a request or when they receive a request for data. And simply, that is what it is about. And we have working examples across some other international jurisdictions. This is how it should look like. If you were to draw the current state of the picture, most likely you will see every single provincial health system in the center and everybody revolving around that in an orbit. That is the current state. But this actually changes this is the transformation imperative there. Yes, for point of care, do we have to actually start looking at from this perspective? AI, I think no conversation will go without AI, but I think, we are at that point, yes, all the big hyperscalers are investing billions of dollars in AI. There is a tremendous amount of potential they are promising. But I think we can pragmatically take the good things out of those AI and start to implement, because where we often fail is we don't even do a good job with the basics of AI. And I think we've been celebrating since morning the AI Scribe program. But I think we all should, in all fairness, say that that is a basic thing within AI, and we're celebrating that. So it means that, somewhere there, we often fall back and falter in implementation even of the basic things. So I think we have to make sure that, we don't just treat everything in AI with caution. Some of the, I call it a game changer, but I think it's also an acceleration in the journey of interoperability, where we have been really taking an old approach of taking the programmers, taking the native systems and trying to actually talk to them, each other, building those mappings and everything. Those are all going to be things of the past. And I think there is already strong evidence coming from these studies that, AI could do a better mapping for us and map all the data to the standards. From a care perspective, AI can really find and map a full pathway of care for patients. Regular patient, chronic patient, because the information is spread out. And imagine if you have a trust framework, AI can do a better intelligent job in really mapping out the full pathway of care for those patients. So we have to start looking at that. And then the most important part is really the population health management, public health surveillance, and helping with the research of the data. The fact that, through trust, you have availability of such a richness and diverse data across various health settings, you're able to actually predict better outcomes, from a population health management standpoint. And within the trust, if it took our neighbor friends, 8 to 9 years to actually scale and get there, with AI, we have a very strong acceleration path, if we decide to go down the path of building a trust network or a trust framework, whether it's the verification, whether it's the authentication, whether it's the consent. I think, AI can actually do a better job of managing the full life cycle of consent, from the point of recording the consent to tracking the consent to be able to audit, where a patient's consent, based on patient consent, where the data was used and what it was used for. AI can do a better job than human and in an effective manner to do that. So we have that advantage. And finally, I think interoperability, I would say it starts to become by default if you start to look into this model. And finally, the governance. Benefits on all three fronts, patients, providers, and health system. Something that I had on the previous slide, which I wanted to ask is, maybe I should just ask, how many of you would be comfortable to give your consent to your provider if they tell you that your data is going to be used for health system improvement, research, and better medicine discovery? How many of you would be comfortable? Wow. That's really 9/10 of the people, who were asked this question. So without building trust, without building AI, I don't think, we'll be able to actually give you what you're asking for. And we've been and this is not just now we're hearing this, we've been hearing this, for almost last 3 years, the same 8 in 10 people are saying, yes, we'll be ready to give the consent, but they're worried about, would we be able to actually track down, where our data is being used? And I think we haven't solved that problem from a system perspective, but if we solve that problem, then I think we will be on to the next level very soon. Connectivity. I think the focus now, the last couple of years, when we issued our pan-Canadian interoperability roadmap, we focused very heavily on systems being able to speak to each other, providers being able to speak to each other. But before that, I think we have to now do another step, which is the connectivity, because we have all these wonderful assets. And if we need to provide a better personalized care, we need trusted connectivity. If we need better care transitions, we need better connectivity. Otherwise, it will be through faxes, through phone calls, and there will be certainly gaps in information that will continue to happen. We talked about population health management. And I think the most important factor that I look at it, and I think this is, I'm trying to balance, my finance and healthcare background, is productivity. I think productivity is very, very, very critical. And I believe, I think the connectivity has a direct correlation, with productivity, whichever angle you look at it from a patient, provider, or a health system perspective. Okay, so we talked about, yes, all the good things, nice things, that we could do, our ambitions. So what are we doing about it? Infoway, our team, we're proud to actually start this journey, ambitious journey, without knowing how far we can take it, but we definitely are going to make enough noise and be bold, continue to be bold about this and challenge the status quo, which is what we heard this morning. We have tremendous amount of momentum right now. We never had this amount of readiness in the ecosystem that we have now, whether you look at from the hospital systems, whether you look at from the EMR systems, but private sector in general. I think they're all motivated to do the right thing. Of course, for patient care, but also I think, for their own compelling offerings, within their product. They need to have this connectivity to be able to actually move up the value chain within their products. And then I think we have some great examples in front of us. We talked about, TEFCA, but also I think on the WHO has Global Digital Health Certification Network, that allows 30 plus countries to be able to actually validate and trust each other when they seek care from one country to other country through that common network. So we really have some great examples ahead of us, and we have to bring them to practice, bring them to demonstration and start building on that business case. We launched our blueprint exercise in fall this year. Great participation, from private sector, great participation from all our provincial and territorial partners who have agreed to work with us as advisors and help us guide the direction of the blueprint. Patient's voice, clinician's voice will be an active ingredient in this development of the blueprint. We're definitely working hard to have that blueprint ready for spring time frame. But at the same time, we don't want this to be an exercise on paper. We issue a nice blueprint like we issued EHR blueprint about 10 years back, but we are actively scouting for some use cases where we could apply some of this and show it in the field. So whether it's one province talking to other province, patients that go from PI to Nova Scotia for seeing specialist, electronic referrals, great example, we're actively chasing that. Or whether it's a region within Ontario where we would want at a community level, we would want to connect the health settings. Or whether it's in the immunization space where we could actually bring all the jurisdictions together to build that immunization. So there are a number of use cases, that we're looking at right now aggressively. And my appeal would be, for those of you in this room, if you believe in this, and then I think you should come forward, with some of the use cases and work with us. So that will be my ask of you as we co-design this, as we put this into demonstration, as we want to show this to our stakeholders and build that confidence. But also, I think, each one of us need this demonstration to go back and ask for funding within our own region. So I think this should hopefully help us get there. So that's really about, where we're going. I'm happy to answer any questions. I would also say this is a big macro solution that we're trying to tackle through this. Yes, we may not have addressed all the 100% questions that come with this, but I think we feel 70-80% confident that we know where we're heading, and we'll figure out the rest 20% as we move forward. We should, at the same time, we should also celebrate a number of micro stories, that we heard this morning. I think there is a lot of micro success stories that are happening everywhere in every region. So let's not take anything away from those. But this is a big macro problem that we need to start looking at it. So for those of you who are interested in those micro stories, I think I would highly encourage you to attend all those concurrent sessions that we have planned tomorrow. The team has worked very hard in building the right speakers, bringing the partners to these sessions to showcase, some of the work that is happening on the ground. So it'll be great for you all to see that and support that. So with that, I'll pause and probably open up for Q&A. And Cheryl, thank you for stepping up. I was talking to Cheryl, who's one of our patient partners, and very engaging conversation. I could relate to her story, but also how some of this fits into the real patient experience. So Cheryl, if you could take maybe 60 seconds to share what we discussed last evening. Thank you.
I'm going to go about as fast as I can go because you gave me so much information. I did a lot of research last night on what this was, so I added a little bit. But I'm a 25-year survivor of chronic myelogenous leukemia, and some people in the room may know that that's one of the miraculous leukemias where there's a special oral therapy. So for the last 24 years, I've been on oral therapy that's targeted, but it does hit off-target things, which I didn't know until last year. So good news is my leukemia for a long time has been in deep molecular remission. But my rheumatologist ordered a test for me that I'd never heard about called immunofixation. But because I was being treated at the MUHC, I had at that time through OPAL access to my results. And my results showed me something scary, that I was actually percolating a second blood cancer that I didn't know about, my hematologist didn't know about. So with my friend ChatGPT, who has been programmed to know everything about me, I went and checked out, what does this mean? What does MGUS mean? And it means I'm actually percolating multiple myeloma, which is very serious. So this enabled me to have a discussion with my hematologist, which actually changed the complete trajectory of my treatment, that I would have never been able to have that discussion. So a year ago, he took me off my TKIs, closely monitoring me. I'm still no detection of leukemia. So that's the great news. The bad news is, in January, the MUHC stopped OPAL. I have no more access to my patient information. And in Quebec, we have a 30-day to sometimes more delay of actually seeing our results. So I'm out of the loop on what's going on with me. I don't even see my molecular test anymore. I have to write to the doctor. So I'm thinking if there was this, and then I heard about the fiasco last week of CIFA, and so that's another blow to my trust. But then I saw this, and I thought, wouldn't this be great if Quebec would accept to go on to this project, salvage what they can from CIFA, and then allow the rest of the hospitals in Quebec who have homegrown solutions like OPAL, like what's being used at the Jewish General Hospital, and other systems which would help Quebec keep its innovative sovereignty. We could all hook up together and we would all get our patient information and we would all be able to work on the value-based healthcare aspect. So that's my story.
Oh. And this one really ties back into patients being able to access their full health record from any platform of their choice. Because if you go down the path of a singular channel to provide the access, then it is loaded with complexity. So it doesn't matter, whether you're using a private consumer app for health or whether you're using a portal, you should be still able to get your full view, your labs, your medication, your provincial record, your immunization. So thank you, Cheryl.
Thank you very much. I think this is a fantastic initiative because I think we definitely need that trust framework to enable interoperability. So I'm really glad we're doing it. I think one of the things you said that kind of got me concerned was that you want me to opt in. And 90% of people opted in here, but the reality is that in the real world, only 35% of people will opt in. This is what Australia figured out 10 years ago when they tried their personally controlled electronic health record system. So we may want to think about how we build in the mandatoriness of data sharing, and that people should be allowed to opt out, but should not be asked to opt in, because people don't always know the value of data sharing until they are on the wrong side of that.
Yeah, I think this is always a very passionate conversation across various tables, when it comes to the opt-in or opt-out model or implied opt-in. But I think the second part that you said, ability to opt out and demonstrate that, I think that's a very, very critical piece. I learned something last year talking to my Netherlands friends, so we have an organ donation program here in Canada. And I was discussing, with the Netherlands folks last year, and I said, what type of model do you have? Because here we have an opt-in model. In Netherlands, what I learned was, they had an implied opt-in model when it comes to organ transplant, but you are okay to opt out. And I asked them, okay, what percentage of patients have actually opted out with respect to organ donation? Last year, the number that I heard was about 5 to 6%, and my Netherlands friends are here, they can confirm that, but that's what I heard, only 5 to 6% have opted out so far.
Right.
So, yeah, I don't have the right answer for you, but at least I agree with you, we need to have the right mechanism in the systems or the design to be able to opt out in a secure manner.
Is enshrined, but that way, we're not having to wait for people to opt in, because if we wait, it'll be a long time before everything happens, before data flows.
Thank you. Thank you, Kareem. Okay. I'm getting a timer warning from Krista. Yes? Okay. Yes, please.
Hi, Gay Dolan, HL7 International, nurse for 20 years and standards geek for nurse for 40 years and standards geek for 20 years. Anyway, so TEFCA enables exchange, but it doesn't enable getting the data into your system. In other words, the scary word of write. And so I wondered if you had any comments about that. And I was going to ask that earlier of the large panel this morning, too, is I think that's one of the causes of all these different sign-ons and everything else is because you have to go into each different system because nobody's willing to facilitate right. And I realize as a clinician you have to adjudicate that. But I'm wondering if AI might have a place in that. And if other comments you have about the big resistance of any kind of right.
Yeah, I think there was one of the slide in my content where I was trying to say that, using AI now, I think there's a potential, to do a better identification and authentication, especially when we're talking about the federated testing systems. This model does respect the federation of systems, so you could continue to have your own identity system solutions and everything. It respects that, except that it focuses on how to build that federation of those various identity solutions together. So again, I think we haven't built anything, so far here, but that's our goal. If we could do a minimal viable use case, with a setting or with the region to actually demonstrate. We may not get it right the first time, but we have to go down the path to actually test it out. Okay, thank you. 10 minutes. We also have a 10-minute break. We'll come back here at 2:25, and I promise you the next session is going to be very exciting. Policy meets politics, I'm very, very interested in listening to this, so please come back. Thank you.